My name is Jean Kugubare. I work for the Gates Foundation in Seattle, and I'm responsible for pushing the health systems agenda. So I will be telling you a short story of the quest for measuring health systems and how we can actually improve it. So for those who are in this business of health systems, as I do, for the last, I would say, 20 years, we've been trying to measure the health system's performance. And we haven't got there yet. And today, I will give you one big work that the foundation is actually supporting with other partners, and I'll give you in a minute the names. But think about, if you cannot measure, how do you fund it? How do you make any investment? So this is the question actually Bill Gates have asked us to solve. And we trying to map up the health systems, and I will spare you all the acronyms, all the efforts and different frameworks, but I think I will put it in three ways. First was to develop a framework that can map up the health systems. For those who are not familiar with the health systems, you could probably refer to different frameworks. One which is probably familiar to everyone is the 6 building blocks from WHO, when we have governance, service delivery, human resource, supply chain, health financing, and so forth. But that doesn't tell you the whole story. So we have, with WHO, World Bank, Research for Development, and Ariane Labs for Harvard, tried to develop what we call the Conceptual Framework. And it flows, I would say, logically from, we could say, in 5 domains. The first one, which we could call it like system level and determinants, where we have governance, financing, and the population health needs. Then we have the inputs, name them, money, people, and so forth. And output, usually we go that way, we go to the outputs, and then we have the outcomes. But there's something in the middle that has always been considered to be the most difficult part, because we can still quantify the inputs, and I will see that it's not so easy, but the service delivery. So we have input, it's converted into the output. In the middle, we have the service delivery. How actually these inputs are converted into output. That's a tough, we call it actually black box, because we don't know how a provider actually interacts with a patient in a clinic or in hospital. And that's where the bulk of our, I would say, our effort is now, in trying to identify, I would say, the subdomains under each of those 5 categories. If we take the systems level, for example, you would be amazed to find that today in the health sector, we don't have a good governance framework or measurement. We have like 36 different frameworks for governance, but doesn't really apply to health. So this was one of the tasks that the team was actually working on. We are still actually trying to do something, and we hope to present it soon to you guys and see if it's actually have some face validity. The financing piece, it's relatively, I would say, straightforward, except that we don't have data. We don't have data for how much the government is actually spending on health. I think yesterday in our micro lab, we were trying to show there's a new tool that we call system health accounts. That's actually can map up the money that gets into a system or a country and then how it is used. You can imagine the difficulties at the country level to know how much government is paying, how much donors, how much companies or individuals are paying, and then for what. But also, because we are now in this movement of asking government to do more, What is the fiscal space that the government can actually have on money? How much the GDP, the percentage of GDP is actually done for health? How much the government overall apportion money to health? There were, I think for those who are familiar with the Abuja Declaration, most of the government in Africa have agreed to spend at least 15% of their government budgets to health, which unfortunately haven't happened even during the MDGs era. We have now SDGs, which is even more complicated. How much actually that money is going to primary health care versus secondary or tertiary care. And we have some preliminary data that is actually showing the reverse. There's more money going to hospitals than to primary health care. So all that type of information, we have to sensitize them, put them in a way that policymakers actually can relate to it and make decisions on it. So for financing, it's not because it's my area of expertise, but we have something there to show you. On governance, we are still struggling, and it goes to central level, how the Ministry of Health is governed. We go back to the district or to the clinic, and we are trying to develop something so they see how it's hard. This journey has started like 2 years ago. With all these bright minds on the team, we are still not there. Now, the service delivery part, to look at that interaction between the provider and the patient or the client, has been a very long journey. So there were different models. We were using some of the typical surveys that is done, and we find that there are so many areas that we don't have data today. So we can either make them or really do some serious studies and all. So that's all this element is going to be, we encapsulate it in what we call PHCPI, Primary Healthcare Performance Initiative. So we had worked with ministries of health, government, I think most 20 countries that is on our kind of our counterpart, just to make sure that they can understand it. The aim is actually to be able to have, I wouldn't say one measure, but at least series of key measures per domain, and then we can actually show to policymakers, governments, donors, where to invest money. So that's the first part, the measurement part. So the second one is the improvement strategy, because after all, the aim is not to measure, it's to measure for a reason. So the improvement, we call it improvement strategies, is what if you see that the system has a problem in supply chain? What do you tell a country? How do you, so that's another area that we actually doing a lot of work, and Harvard's Ariane Labs folks are leading that effort to identify the best practices, good lessons across the world that can speak to how do we solve the supply chain? How do you solve the human resource for health and so forth? So there will be a compilation, I would say, in different modules that can be offered to different partners that include the government, so that they know actually what to do with it. And that will help us make the investments, that's the third part. Because once we have the measurement, and we have some solutions, at least a set of solutions. In fact, during the improvement strategies, we also gathered a lot of bright minds in the world, so to speak. And we also identified there was so many missing information that we didn't have on the health system that we actually have to design new ones. So this is going to be an ongoing effort. But at least the solution that already exists can be readily applied. So, and then the third part is once we can measure to see if the system, health systems, is getting stronger, better, and resilient over time, then we can actually make investment. So that's I would say, the cool part of it. And we have tried to work with this big organization, not only because there is no information so today to measure a system, but once we have it, what do we do with it? Now, we could see this happening. Actually, we see it happening right now for those who are familiar with the GFF, the Global Facility Financing. So if you want to invest money and improve the MNCH, the maternal child health program, and because of the precedent we had with vertical programs, TB, we are very good at it. We can actually measure the impact of our program, vertical programs, malaria, TB, number of people who are even immunization. So those ones, but how about you doing a good job in HIV, but at the same time decreasing the performance of your system because you are pulling all the resources to HIV. So that element, even donors actually need to see it, that whatever programs they're bringing in a country is not having an adverse effect to the overall systems. So I think we're doing this advocacy work with our different donors. So let's have a comprehensive approach. Even if you have your specialty in HIV or in HRH, if you see this overall measure of performance is going down, whereas maybe your program is doing better, you probably have to recalibrate. So that will actually give us a good example for countries who are now embarking on health reform, strategic reforms, and so forth. Where the system is failing, what exactly are we going to address? That's the solution, or improvement solutions will come to bear, because it's already proven. So it'll be easy for any group or any program to write a nice concept note, a good proposal, because actually we're going to address the issue that have been measured, and then for the first time, we will be able to measure over time to see if your program is going well, but also the overall health system is going better. So that's the whole process of this exercise. And we had a preliminary meeting in Johannesburg last year in November with 23 countries, where we actually presented some of the data we have collected. We are not actually creating new data. Most of them actually do exist, except few missing pieces, and then say, how do you feel about your country performance? And it's not an easy task, because basically, I mean, we have another idea of, we will certainly compare countries now. We have a place where we can compare, and we will rank countries. We will be able to say, you should probably look at your neighbor. There's actually a similar activity that the foundation is also finding, the comparative health system, that to make sure that people actually learn from each other. And then, during that 2 days workshop in Johannesburg, we presented the results. I mean, most of the folks who were coming was high senior officials in the ministries. I think there was certainly yes, we can see ourselves there. No, we don't see ourselves. So we have to recalibrate some of the numbers. But at the end of the day, because we have 5 domains, and under each domain we have 5 to 10 subdomains, so at the end we have 36 subdomains, and we have to combine all of these things maybe in 5 numbers. Hopefully at the end, if we can survive this exercise in 1. And it's not easy because it has to be a lot of advocacy piece under it. And then we see the reaction from the countries, and we were, 2 weeks ago in Geneva with experts trying to say, is this combination make sense? Could we actually have one number for, let's say, system financing, though we have 5 subdomains? Could we combine the service delivery into one performance? So that's the job we are working on. So we expect to get this with countries this time, though it was launched 2 years ago, but this time I think during the 40 years of Al-Mahata, we will be presenting at least this 20 or 15 to 20 countries that say, yes, this is our numbers. We stand by. We will continue to work on it. And then the ultimate goal will be twofold. One, we get the policymakers for the first time to actually look at their performance of health systems. So that will be a good thing for a president or a prime minister or even the minister of health, and also be able to compare with the peers and maybe hopefully learn from other peers, but also this time commit funding, not only from donors, but also for the country, because very rarely we will find a donor that commits to fund entire health systems. So if we could, even if we are working on malaria or HIV, put maybe 10, 15% for the health system so that actually we can fix the thing that we, thank you. So we might even increase the percentage. How about 25%? That's coming from the government. But also, this could also be by the way, it's going to be on one page, so it won't be like different pages. So we can actually have one page, and if it could be like elevator speech to the president or to the prime minister. Says, this is your country. That's where you are. You are not doing good, but it's a vital sign. It's like a patient comes to see you, you take a blood pressure. You can say, yeah, we are doing fine. But if you want to know more, then we go down and we dive into the subdomains and solutions. So that's the process. But there's also another tool for the donors. Because if a donor wants to support a program, we would tell the donor, hey, this is your program, but your program will never work unless you fix HRH, human for resource. Or, yeah, because you cannot, I recall the early days with this vertical program, I won't give the names here, but they will solely devote all the funding, and they have their health systems under one disease. People, supply chain, and so forth. So even information systems, it's just a little bit disturbing to see different information system and taking one piece of, it's like you have a patient, just take blood, but you don't relate to the weight and so forth. So that will be another appeal to the donors to use this tool for their own, and then the technicians who really are researchers, like you all here, will be able to support the development of a new knowledge about the missing piece that we have identified under the health systems. So that's the long, short story of the health systems and its measurement and improvement. I thank you for your attention. Yeah.